My name is Dr. David Maddie. I am a clinical assistant professor at the University of Louisville School of Dentistry, and I am the course director for a class that we teach to our second-year students that is titled Preclinical Occlusion and TMD. And from the development of that class, I have created a mini-series in conjunction with the Dawson Academy that I title Functional Occlusion and Advanced Restorative Concepts for Dental Students. And the hopes are that other dental schools will use this in their curriculum. It consists of 6 lectures. In the first lecture, we make a definition of occlusal disease and present a case that is the third major daily seen dental disease following caries and periodontal. And then I go into a 3-lecture series that defines what we are calling a perfected occlusion, so that we have a standard to talk about an ideal functional scheme. And then I develop this concept of the dilemma that occurs as we look at most occlusions and we see various degrees of breakdown and or dysfunction. And the last in this series is a conversation of how to evaluate and diagnose our patients, putting them into categories that can help in treatment planning concepts and decisions. Acknowledgments are given to 3 major sources of information that was used to gather the data in the use of this mini-series. The first is a textbook written by Dr. Dawson titled Functional Occlusion from TMJ to Smile Design, and by far the bulk of the information is directly from his book or is from materials directly donated by Dr. Cranham, who is the director of the Dawson Academy. The second source of information is used in some of the details of the temporomandibular dysfunction, and that is called Management of Temporomandibular Disorders and Occlusion, and that is a textbook written by Dr. Jeffrey Occlusal. BiteFX is a software company that creates software to sell to dentists in case presentations, and the value of this donation is that the animations that you will see throughout the series are useful in helping to visualize some of the complexities that occur within the 3-dimensional joint and or muscles. And you'll see when there is a referenced area, there'll be a small icon in the bottom right-hand corner to acknowledge the source of the information on that particular PowerPoint slide. Lecture number 1. One must make a diagnosis. Well, in your dental training, you have most likely already been exposed to caries. You've learned its etiology, you've learned how to identify it, you've learned maybe some of the treatment options that are available. You've also learned about periodontal disease in detail, its etiology, its diagnosis, its signs and symptoms, possible treatment options. What I'd like to do now is kind of look at a different type of scenario. And we're going to look at this smile together, and we're going to ask ourselves, what can we deduce by looking at these patients' teeth? Give you a second to kind of look. If we look here, we can see that the incisal ledges are wearing, they're worn. Of course, when the teeth came in, they had mamelons, and those are long gone. If we look here, we look at individual teeth, particularly in the lower anterior, and if you get the light just at the right angle, you'll see a bunch of lines or crazes. They're light cracks that run in a vertical fashion. That just tells us that there's a whole lot of force being exerted on these teeth. We look here on the picture on the left, we'll see that there are some crowns that have been made in the back of the mouth. Look at the front, and it looks like there's a pretty deep overbite. There's not much of the lower anteriors showing anymore. If we look at the occlusal surface of the maxillary, we'll see that the incisal edges are worn. That inner darker part is the dentin. If we look Where the molar is, we can see a large amalgam. It's a mesiolingual, which means the mesiolingual cusp was replaced for some reason. It's old, I can tell, because the staining into the distal part of the tooth, you can see the black staining that is occurring through the dentin from the amalgam. If you look at the tooth in front of it, there's a small occlusal filling, but just on the edge of that occlusal filling, connecting into that filling on the molar, there's a tiny crack running right through the distal marginal ridge. Look over on the other side, we see that there's a couple crowns that have been made. Looking at the bottom teeth, we can see that there is wear of the lower incisors. Again, you can see the dentin and the chipping. Look in the back here. We got two crowns on one side and one crown on the other, and they kind of look different. You know, maybe they were done at different times, and maybe even different dentists, because they have a different style. Now, we can deduce at this point that this has been a pretty compliant patient. See, crowns, as you know, are costly. They require an investment, and that it looks like he's had, I don't know, 6 or 7 crowns maybe. And so we can deduce from that that when something has gone wrong and he has seen the dentist, he's done what the dentist has said to do, and he's been compliant. And he's probably been a very good patient. All right, let's look and ask ourselves, is there or was there ever a high caries rate? And I'm going to think probably not. There's no fillings in the anterior. There's been no decay in the anterior. The only thing that has been restored is in the posterior. And the posterior looks more like it's not from cavities, but maybe things breaking, or maybe falling apart, or cracking. Let's ask ourselves about the periodontium. How does it look? Is it likely diseased? And from the outside, it doesn't appear so. The color is pink, it's firm, it's not swollen, there's no marginal gingivitis. You know, he takes good care of it. It's likely, just in a general deduction, that his periodontium is probably stable. But boy, things are falling apart. Things are wearing down, and they're cracking, and they're breaking. There's a bunch of crowns in his mouth. And we're not thinking there's cavities, and we're not thinking there's gum problems. So we ask ourselves, what's going on here? What would you do if you had this patient? You know, would you leave it alone? Would you try to fix something? It's likely that he's probably going to the dentist and something breaks. He shows up. Maybe they make a crown to correct it. And then that's probably been his pattern. And so what would you do? Would you do the same? Would you just continue and wait for more breakage to occur and let more wear occur? What if I told you the patient was a 91? Would that matter? Well, probably. You know, it's likely not to be a restorative problem if somebody's 91. What if I told you they were 32? Well, that might change things. That's a lot of wear, a lot of cracking, a lot of previous crowns for a 32-year-old. What if I told you they were 60? And that's what this man's age is 60. But what if I told you that his wife wanted him to have a prettier smile, and that his teeth are getting darker and they're wearing down and they're showing less, and she wants him to have a pretty smile? You know, what would you do? Would you know how to do it? You know, could you do things that might be harmful with knowledge? How about this patient? Let's kind of zoom in a little bit and look at this back molar. If you look right there, you see that's a flat spot. That's called a wear facet. Now, the tooth didn't come in like that. It's flat because it's rubbing against the tooth that opposes it, and they flatten each other out. So now let's look at the front. See, the edges are worn. In this one, you can see the dentin coming through. So there is incisal edge destruction occurring. So what would you do? What if I told you the patient was 91? Well, it probably wouldn't matter. The patient is not likely to lose their teeth at 91 based on what this looks like. What if they were 60? Maybe they could live to 91. That's a lot of destruction. You might consider things. What if I told you there were 22? And that is the age of this patient. Look at the destruction in the anterior. Could that back be connected to it? So you ask yourself, what's going on here? Now I want to ask you, what major dental diseases will you see every day? Think about that a minute. You think you'll see periapical abscesses every day? Probably not. So what is an everyday finding? What is your common daily diagnosis? Well, of course, it's caries. You know that. And you'll see periodontal disease every day. But I contend that there is a third disease that is a major dental disease that you will see every single day, and we're going to call that occlusal disease. So now we have 3 major diseases for us to understand in detail and diagnose and treat. Occlusal disease is the deformation or disturbance of function of any structures within the masticatory system that are in disequilibrium with a harmonious interrelationship between the TMJs, the masticatory musculature, and the occluding surfaces of the teeth, or, easier said, are the teeth, muscles, and joint in harmony with each other. Think of it as a system of balance and harmony between the teeth, muscles, and joint. Dr. Dawson states that whether a general practitioner or specialist practicing without a comprehensive understanding of occlusal principles exacts a costly penalty in missed diagnoses, unpredictable treatment results, and lost production time. And amongst many things, Dr. Dawson is noted for his book, Functional Occlusion, From TMJ to Smile Design. And as I stated before, a lot of the content is from this book. But first, in order to include that third disease, which we call occlusal disease, first we must make a diagnosis. Let's think a little bit. Patient comes in, and you're about ready to start your new patient comprehensive exam. So what might be some of the things that you should do, or maybe would do, or would like to do when you first meet someone to be thorough in a comprehensive evaluation? Think about that for just a pause. And so, of course, we need a health history, dental history, appropriate radiographs, soft tissue exam, always checking for oral cancer. Other diagnostic records might be values such as photos or study models. And a hard tissue exam, certainly we look for caries and periodontal disease. And so now we have a new component we have to add, and we're going to do that, and we're going to call it an occlusion examination. So when we do an occlusion examination, not only do we need to look, but we need to write, and we should have a diagnosis. So just for an example, back years ago when I graduated, there was not good charting for occlusal exams, so I created my own. And this is a form that I used for the full 31 years that I practiced, as I discovered and evaluated the occlusion in each and every one of my patients. So first I would start by looking at teeth. I would look at function and sliding and grinding and bouncing contacts and such things. Then I would look for some signs and symptoms of occlusal disease. And then I would do a muscle palpation test, look for sensitivities. And this particular person had chronic repetitive temporal tension occlusal spasm headaches. And then I'd end up with a diagnosis or a summary. And so I'm not showing you this as this is the right way, but my point is that if we're going to include it in the examination, not only do we need to look, we need to write and notate and come up with a conclusion. I'm going to let Dr. Cranham, the director of the Dawson Academy, speak to this concept of cause and effect. And so I'll go ahead and start him now.
So you've learned already in some of your training this concept of cause and effect. And the really good news for us in this masticatory system, we'll refer to that, the masticatory system, the relationship between the joints, vessels, and teeth, is there really are only 2 causative factors that cause problems for us. The first causative factor you've already learned a lot about, and that is really microorganisms. And so you can have a cause, which is the plaque and bacteria, And depending on the bacteria, you're either going to get periodontal inflammation, which can lead to breakdown and bone loss, or it could also be caries, right? So you can either get bugs causing caries, gum disease, and what's interesting in private practice is that, and I've noticed over the years, is it seems like it's one or the other. A lot of people with a lot of periodontal disease don't seem to get a lot of cavities, and often the same way goes the other way as well.
So now we're going to have him talk to you about causative factor number 2. Now, when you listen to him, I want you to note that he will give a list of scenarios that could happen. And this is a key concept when understanding the system of teeth, muscles, and joint. And he says what could happen. It doesn't mean that each one will happen. And we'll come back to this point as these lecture series develop.
The other causative factor that I want you to think about is the force on the teeth. And so what I want you to start grasping is that if we have a high tooth or a tooth that's interfering with the mandibular movements and the tooth is rubbing, and we'll talk about why this occurs, we can actually set up this problem where we get not only an increase in muscle activity, but a hyperactivity of the muscles and incoordination of the muscles, where we start putting extra force on the system. And what's intriguing about this is that you could, if you somehow in a laboratory, if you took 10 people and you could set up the same occlusal interference on the exact same tooth, it's very likely that the 10 people would break down 10 different ways. Somebody might break that tooth, somebody might wear that tooth, somebody else might work it loose, somebody else might break bone around the tooth. Other people might avoid the contact and start getting the muscles sore. Other people might get an issue with the joint where the disc starts popping around and clicking. You might have all the things going on, and yet other people adapt. Other people just adapt to it, and that's sort of the miracle of the system. But I want you to start thinking about causative factor number 2 being stress to the system. Not stress like I hate my mother. I'm talking about force, all right? I'm talking about force generated from muscle activity. So stress is going to equal occlusal overload, which is going to lead to what we're going to determine or call occlusal disease. And this is a concept that I really didn't start understanding till getting out in school, but there are people out there that will have the propensity to tear up your work. And so if they're one of those folks that tends to brux and grind and parafunction, we have to start understanding there are ways that we can make the teeth fit together. There are principles that we can follow to better balance the bite and put appropriate forces on the teeth. That's what occlusion is about. That's what it is.
Occlusion is the study about force management. It's about learning how to make the teeth fit together and separate to create optimum function and stability. And one of the purposes of this lecture series that I will be taking you through will be to look at those principles and look for concepts on how to manage force in a way that it does not become destructive. Occlusion is about force management. Are the teeth, the muscles, and the joint in harmony with each other? Think of it as a system, a balance between and keeping them in harmony with each other. What is the most untapped need in most dental practices? The number one cause of tooth loss, the number one cause of patient discomfort, the number one cause of dissatisfaction, the number one cause of orofacial pain, the number one misdiagnosis, the number one undiagnosed problem. Well, it's occlusal disease. Now, this is what Dr. Dawson has stated in his book. And so imagine this, if that is true, and I contend that it is through my years of experience, but if this is true, and we're not even identifying it as a disease, much less looking for it or writing it down or diagnosing, look at what we could be missing. Look at what types of destruction could be occurring within our patient population and to the extent of the disease and the destruction that occurs. Diagnosis starts with identifying signs and symptoms. Of course, you remember that signs are what clinicians find, symptoms are what the patient finds, and you've studied a lot so far about periodontal disease, and you know that you're to take a periodontal probe, put it in the pocket, and touch, and if you see any hemorrhaging upon light probing, that could be a sign of inflammation, or maybe you see a lot of plaque, or maybe you see the depth of the pocket deepening, and so you've been taught how to identify the signs of periodontal disease, or cavities, for example, caries. We take x-rays, we take bite wings, and what we're doing is we're looking in the back for small carious lesions, such as right here, in an proximal decay that's just beginning. That's not hurting the patient yet. The patient isn't aware. That's a sign. So you've been taught the signs and symptoms of caries and periodontal disease. So what are the signs of occlusal disease? Or, let's say it this way. What are the signs of instability? SOI. Because that really is the result of occlusal disease. Well, first we have wear. These incisal edges just don't happen that way. They happen because they're rubbing against the adjacent teeth. So, first sign. Mobilities. We're not talking about big mobilities. We're talking about small mobilities. You put two ends of a mirror handle and wiggle back and forth, and you look closely. And often we can see these mobilities in the x-rays. If we look at the lower towards the apices, you see the widened periodontal ligament. And of course, you see there's generalized bone loss as well in tartar or calculus. But I've seen many times when this is cleaned up and properly treated by a periodontist, and then the occlusal forces are balanced, that widened periodontal ligament will disappear, just like it looks on the adjacent laterals. Or you see it particularly around second maxillary molars. That's a real common area, and if you were to look in the mouth and touch the teeth lightly, you would see small bouncing up and down. And this is common in this area because it's the closest back to the fulcrum or the joint, and that particular tooth tends to be the one that tends to interfere with the complete seating of the condyle, and we'll talk about that in later depth as these lectures go. Migrations and movements, and here's your classic. You take out a mandibular first molar and things start to move and shift and supererupt and collapse. And so these are instability. That bite is not staying stable through time. Fractured or broken teeth. Teeth don't break from chewing mashed potatoes. They break because of excessive forces, or sometimes they even split. Needs to have a whole lot of force going on to actually split a tooth. Certain types of non-carious cervical lesions are signs of instability. Sore muscles, sometimes headaches, and some Team J issues are examples of signs of instability. Early detection starts with identifying these signs. We don't want to notice it at this stage. We don't want to tell a patient that there's no tooth left because they've been grinding their teeth for most of their life. And I can tell you, I've done that before, and people have said to me, gosh, no one has ever told me that before. These patients often don't have any sense or awareness that that's what they're doing. This is when we want to find it. Look at these incisal edges. Look at that dentin is just getting exposed. This is a young person. This is a person that might end up like that previous photo. Occlusal disease is always progressive. If we look at these incisal edges, we can see there's a little bit of chipping going on in the enamel. We can see that the dentin is exposed. And if we go a little bit longer, and we look at once dentin is exposed, incisal wear happens 7 to 9 times faster. And through time, you'll start to notice in some people, chemical erosion occurs. And you'll see that that dentin is chemically eroding, but the enamel is taller. The dentin isn't disappearing because it's rubbing because it can't touch, because the enamel is still in contact. And so as that chemical erosion occurs, that enamel gets more undermined, it starts to chip, it starts to break down, which causes the dentin or the wear to happen 7 to 9 times faster. Edges start to break down like this as it progresses, and then all of a sudden there's no lower teeth that are really ground down. And we have anterior relationship changes in the arches. And then we have our classic nub, is what I call it, when there's just nothing left but just tooth down to the bone almost. And of course, extremely bad here, we have exostosis, and we don't want to tell people at this stage. So what I want you to do is I want you to think of that incisal edge was as it wears, and as soon as it breaks through that dentin, think of it as an open wound, maybe a diabetic open wound. It just won't heal. That just gets progressively worse and worse through times. Signs of occlusal disease almost always precede symptoms. So if we have a tooth, let's say we create this tooth and it's a little tall in our filling or our crown, and it could be that that tooth might get tender and sensitive, maybe the one above it or the one that is that way. We can get sensitive or sore teeth, or maybe that sign, that tooth that's a little tall might cause excessive muscle activity, which can cause soreness or painful muscles, which could even lead to certain types of TMDs. Or it could be that high tooth or that tall tooth, that occlusal interference, has no symptom at all. Think of what Dr. Cranon talked about in causative factor number 2. Possibilities can occur. It doesn't mean that they will, because some people just adapt. Let's have a look at non-carious cervical lesions. Sometimes we call these abfractions. Well, often you get bone loss, which potentiates periodontal disease. We lose our attachment often, no more attached gingiva, which makes the recession go quicker. And if you try to put fillings in some of these people, they tend to pop out, and they're just kind of downright ugly. Now let's compare a couple types of non-carious cervical lesions. We're going to differentiate between what we all know of as abfractions versus abfrictions. Abfractions are a combination of the torquing of the tooth and the toothpaste. You see, as the torquing of the tooth occurs, the dentinal tubules become weakened, and then the friction from the toothpaste breaks them off. On abfrictions, there's no torquing of the tooth. It's just the friction from the toothpaste. Abfractions, you have to have a lateral force. You have to have contact in maybe a group function or a bouncing contact. But abfrictions, there is no lateral force contact. Abfractions often have a V shape. Abfrictions often have a U shape. Abfractions often are subgingival. Abfrictions are not subgingival. So let's look at an abfraction and do a close-up. We can see we have our V shape, and we can also see that that tooth was in contact in lateral forces. There is a relationship between occlusal disease and periodontal disease, and it deals with hypermobility. And here's one study, and there's many out there, that show evidence of association between untreated occlusal discrepancies and the progression of periodontal disease. Kind of looks like this. The picture on the left is going to be a closure in the back with a protective bite, and the one on the right will be one that is an unprotected bite. And you can see what happens as they grind, that you can create the mobilities, which tends to have a preponderance to help break down the supporting bone. Occlusal disease causes instability. And so now when you see this type of thing and somebody comes in with a broken cusp, you want to ask yourself, why did this tooth fracture? Was it from chewing? Was it chewing the actual cause or the last straw? Could have been prevented by an astute dentist. Or we look at this, and we see that breakage. And this will ruin your day, these nice pretty porcelain crowns, and they're only in there a month or 6 months, and somebody comes in like this. So you say, why did the crown fracture? Was it poor lab technique? Well, a lot of people are going to blame it on the lab. They're going to think the lab didn't do it right, or maybe you didn't bond it right. Could it have been something the dentist had done in the design of the crown from the lack of knowledge? And I would say probably in this case. See, I think that tooth originally was probably only this long, and I'm judging that based on how much tooth is left. So sometimes you create too long of teeth that can cause trouble. And we'll talk about that more so in a couple lectures from now. The study of occlusion is about force management. It is about learning how to make the teeth fit together and separate to create optimum function and stability. Think of it as a system. Are the teeth, the muscles, and joint in harmony with each other? Force management. So what is the key take-home thought today? Well, we have 3 major dental diseases, not just 2. Of course, caries, periodontal disease, and now we have occlusal disease. And this really is good because it gives you a whole nother way to think. It also helps you be more comprehensive in your evaluation and often more comprehensive in your treatment, because it's common that the occlusal disease needs to be managed with more types of treatments or different options available to us. What now? Well, the teeth must fit into the harmony of the jaw relationship, not the other way around. So what I'd like to do at this point is let Dr. Dawson speak to you about this concept that he calls the inverted tripod. And what I'm going to let him do is he's going to walk through the whole concept in just a couple minutes, and then I'm going to spend the next 3 lectures dwelling into this into deeper. But I'm going to have him give you the whole story just to start with.
One of the best ways that I think we have of helping you understand mandibular function, and particularly a stable occlusion, is to look at the mandible as an inverted tripod with the condyles in the back and the anterior teeth in the front. The anterior represented here would be 6 lower anterior teeth against 6 upper anterior teeth. We want to look at this from a standpoint of 2 critical stopping points for jaw closure in a perfected occlusion. Now, the stopping points are what stops the jaw in its closing position in a very stable relationship. Well, it starts with the back end of the mandible. And what we want you to understand here is that when those condyles are seated, condyle disc assemblies are seated up, they're stopped against a bony stop. A centric relation is the highest point the condyles can go. That means they're stopped by bone. The reason this is so important is because this is a very stable relationship. It's a physiologic relationship. It's an automatic relationship that coordinated muscle will pull those condyles up the eminence to the fully seated position and brace them upwardly against bone. So they can't go any higher. You can lift the patient out of a chair and you can't make those condyles go higher. So that's the starting point of occlusion. All right, then the second thing is we want a definitive stop in the front. And so that when the jaw closes with the condyles fully seated, we want that anterior teeth to contact the cingulum if possible, a definitive holding contact where not a steep incline, but a stop, so that it's a very solid closing stop. Can't go any higher than in the front. So the mandible can't go higher in the front. It can't go any higher in the back. That's a position that we want to be able to maintain with everything else we do. When we want to establish the anterior relationship with very stable holding contacts in the front, in combination with completely seated joints in the back, and then we can put back teeth in between the condyles in the back and the anterior guidance in the front, and we can put them in there with perfection, with equal intensity, because the condyles can't go higher in the back and the anteriors can't go higher in the front. So we can get an absolutely perfect occlusion. We can do this with equilibration. We can do it with restorations. We can do it with orthodontics. But we have to understand the principle here. And that principle is centric relation. The centric relation is that uppermost position in the back, and the other stopping point is anterior contact. So what's our goal then? Well, our goal is no interference from posterior teeth. This is an absolute essential to understand. We don't want posterior teeth that interfere with either complete seating of the condyles in the back or the anterior guidance in the front. So we want no interference from posterior teeth to complete seating of the condyles and stable holding contact on the anterior teeth. Now, we have to accomplish this to achieve a stability of our occlusion. Now that means we have to understand the temporomandibular joints in the back, and we have to understand anterior guidance in the front. And believe me, if you get these 2 aspects of understanding of occlusion, the rest starts to get pretty simple, to tell you the truth. Back teeth are easy once we establish the two endpoints for the front and the back. So when we say no interference from posterior teeth, we mean no interference. We don't want a back tooth striking even a few microns sooner than the front teeth contact in centric.
Next week, we'll be going into more detail of this inverted tripod concept, and we're going to define a perfected occlusion, and we're going to use that as a basis for understanding the potential treatment goal we could develop in the future. And we're going to break it down into 3 lectures. We're going to talk about the back, which is the T and J in centric relation, and then we will come to the front for the anterior contact and guidance, and then we'll talk about what's left in the middle, creating posterior non-interfering contact.